So Dr. Santosh, excellent uro-oncologist and a dear friend. And Dr. Santosh has, trained in India and is currently in the United Kingdom in a very high volume focal therapy center, which is University College of London Hospital. And what is commendable about Dr. Santosh, after having finished his robotics urology training, robotic uro-oncology fellowship in Mumbai, was practicing as a consultant. He left a plum opportunity to be in India and serve, and just so that he could go and learn newer techniques and probably bring them back to India. So he has seen the whole spectrum from radical surgery to focal therapy. And he's currently a clinical fellow at the University College of London, working with some leading focal therapists of the world. And Dr. Santosh, it would be a pleasure to have your talk on focal therapy state of the art.
Thanks, Ashwin. I'm just sharing my slides. Can you see them?
Yeah, we can see them now, Santosh.
Okay, thank you. So thanks, Ashwin. And I think I totally agree that pathologists are very important, especially from focal point of view. And I'm going to quickly run through this. So disclosures would be, I don't have any company affiliation. I'm a uro-oncologist. I'm a trained robotic surgeon. I'm also trained in focal therapy. So I sit on both sides of the table to have a wider perspective about the subject. I would be covering the topic in looking at traditional approaches, why focal, two important determinants of focal therapy, types of focal therapy, and brief literature review. We all know that digital rectal examination, PSA testing, ultrasound, and biopsy and MRI are something which we do to do prostate cancer risk assessment. And once the risk is assessed, we either do an active surveillance or surgery and radiation. There are few people who would go into only hormones or watchful waiting. But there is a spectrum of patient in between that I'm going to talk about, which would be asked to undergo focal therapy. Now, is there a need of focal therapy? The question commonly asked is the focal therapy still knocking on the doors? My answer to it is the era of knocking on the door is gone. It is already in the house, sitting on the table and having a meal with everyone else. So if we look at this paper, there are some variations in patient-reported urinary outcome 3 months after radical prostatectomy. It's a statewide study. And even now, the rates of adequate erectile function after radical prostatectomy do not appear to have improved over the last decade. We looked at our own data of 2,000 men in UK after prostatectomy, looking at their status in leaking urine and erections. We found that men after prostatectomy, 1 in 3 need pads at 12 months, which will approximate to a mean epic domain score of 78. And in men with erections sufficient enough for intercourse with no assistance, 1 in 20 had erections without assistance, which would be a mean epic domain score of 34.8. With radical radiotherapy, we all know that impotence and urinary issues is an issue, and rectal toxicity is where radiotherapy scores much over radical surgery and focal therapy. Active surveillance has its own challenges. It can be associated with anxiety. Men with intermediate risk prostate cancer have 50% chance of delayed treatment and risk of stage progression around 1 to 2% of MRI visible 3+4 disease. Now, can focal therapy, can it join the venue? It can, and let's see how. It started with the concept of Halstead doing mastectomies, radical mastectomies, went down to lumpectomy, and somebody picked up the concept in prostate, and Hush Ahmed from UK has published this paper. They looked at index lesion as the main lesion contributing to the spread of disease and not multifocality. And he went on to add another paper saying that the genetic composition of patients who've got METs or who have spread of disease is similar to the index lesion. So the concept coming up was, if we treat the index lesion right at the start, do we help to get the patient avoid any metastasis or spread of disease or progression of disease? Now, the next question is, what is focal therapy? There are many definitions available. There are many definitions that I've heard, but what I like to keep it simple, what I tell the patient is it's a type of tissue preserving surgery which treats that part of the prostate which has MR visible cancer, which is localized and clinically significant prostate cancer. Now, these two words are very important. I'll emphasize now. We asked a group of experts. Now, what is the three most important criteria they look into whether when they decide to put the patient on active surveillance or active treatment? Gleason grade, MRI, and PSA density were the first three as a consensus with all the consultants. We all know that most of the patients would be Gleason 3+4 going for prostatectomies. And we also know that the percentage of pattern 4, as explained in the previous talk, is extremely important because that defines how the prostate cancer will behave after the treatment is delivered to the patient. The second most important point after Gleason score is MR visibility. MRI gives us information and location of the tumor. Some papers looked at it after prostatectomy and they found that MR visible disease, 40% have biochemical recurrence, 20% have metastatic disease at 15 years, and 7% prostate cancer have mortality. There are papers which also suggested there are 3 times more likely to lead to biochemical recurrence after radical treatment than non-visible disease. Genetic sciences also emphasize that MR visible have got different genetic composition, which makes it probably more aggressive than non-visible disease. And this paper from our side looked at 5-year data on patients with active surveillance. We have a 10-year data coming up. It's all for publication. I can't divulge the readings, but what it said is that 3+3 visible disease tends to progress more than 3+3 non-visible. 3+4 visible disease is more aggressive than 3+4 non-visible disease. So we are going into the visibility of prostate cancer. Hence, prostate cancer MRI allows us to see cancer differently, and seeing cancer differently allows us to treat cancer differently. So does one modality fit all? Certainly not. When you look at indications, as I said, we have got Gleason 3+4 and some cohort of 4+3, 4+4, which is subject to patient discussion. And the contralateral side, if it is low volume 3+3, 5 mm, it can be kept on active surveillance. To add to this, I would also put in the MRI criteria of whether it is seen properly on the MRI, because we need to get a margin around the cancer when you treat it, and where is the location of the tumor to select the type of procedure you want to do. So if I want to go back, you see anterior tumors are treated with cryotherapy and cryotherapy and nanoknife. Posterior are treated with HIFU. These are the types of focal therapy. I would restrict myself to first 3 because that's what I'm trained in and that's what I do. And as I said, the anterior gland are more treated with needle-based transperineal therapies like cryotherapy and electroporation. I'll discuss that in a moment. And posterior gland are treated with ultrasound-based treatment called HIFU. Now, this is a HIFU. You can see the ultrasound machine there, and that's how the ultrasound generates heat at a focal point, and that starts to burn the cancer. It's like using a magnifying glass against the sun, and if you focus it on a piece of paper, the paper will burn, but nothing in between that. If you move ahead, so this is one tumor I want to show where you have a left low T2 signal in the PZ, and there is the effusion. The biopsy showed 3+4, 12 millimeter prostate cancer, and he underwent HIFU. You can see I'm showing with the marker on the top left side, you can see white changes. They're called Ushida changes, where the cancer is getting heated up, cooked up. And on the right side, we monitor any complications or any heating in the rectum, which we can address immediately to avoid any complication. And these are the sectors which we treat with the cancer. And this is what it looks like after it is treated. The whole cancer is being treated and there is no visible evidence of any effusion or any enhancement is seen in the MRI. Cryotherapy is making ice balls in the prostate, where you can see an ice ball is created, and that's how it kills the cancer. If we go to the next slide, you can see this is what I've shot, and this is how the probes produce the ice ball in vitro. So going to the next slide. This is one patient I wanted to show. This is an anterior tumor. You can see in the TZ, the needles are placed in. And when we go in, you can see the ice ball expanding on the left top side. That's the ice ball expanding and killing the cancer. And that's on the sagittal view, you can see the ice ball treating the cancer as well. Nano knife for electroporation is generating electric current enough to not cause heat. Now, what it does, it opens up nanopores. This is an electromicrograph of the cell, and when the nanopores are opened, that causes the cell to undergo autolysis. And this is another treatment. That's the patient in lithotomy position. You can see that's the tumor on the top left, and that's the yellow dots are showing how the needles are placed around the tumor, and that's the red thing is showing the electric field that is generated along it in between the two needles to destroy that's the real needle placement, ultrasound view. And this actually what happens, it's called pulse treatment. You can see the electric current killing the cells. And at the end of it, you can see this cavity here. And that's how. Let's look at the trial which affects routine practice. Now, in focal therapy in UCLA started off treating all the cancer. We gradually moved on to focusing only on the area which has cancer in it. And now we practice what is called as lesion control, HIFU, where we focus on only clinically significant cancer and the other cancer is left behind. When we looked at all these treatment modalities, we saw a very good drop in PSA after treatment. And we also saw that the erections were sufficient enough, and which was a good sign, and which shows that the patient can have good functional outcomes after treatment in forms of erections and passing urine. Rectal toxicity is practically zero. And if we move ahead, this is the recent study which looks at focal ablation in 56 men. And you see around 89 to 90% of these men had no clinically significant Gleason score, Gleason 3+4 or more, on treated side at 6 to 12 months. That's when we used to do the biopsies, but now we don't do any biopsies after focal treatment. This is a repetition of the slide which shows which treatment to use when. Now, why is it important to divide treatment into anterior posterior? Our study showed that there is treatment failure around 20% in posterior tumors, around 37% in anterior tumors. So the dictum is only use HIFU for anterior treatment if there is very small gland. It involves a little bit of calculations and measurements on the MRI, but you need to be very clear of what you are choosing. What margin should we apply? Now, if the radiologist draw a margin around the tumor and we treat it, we are going to miss 15%. Hence, the recommendation is take margin of 9 millimeter to cover 100% of histology volume. Now, what happens when we move from clinical studies to routine care? Now, this is a study done at our center by Armando, and we look at 70, as expected, 70% was focal therapy, 30% for hemiablation. Most of the Gleasons was 3+4, which was treated by us. We went down on 3+3 only if it is significant, only if it is visible, the patient wants it, we give it. And small cohort of patients of 4+3 receive the treatment. The overall survival is 97.3% at 5 years. Radical treatment-free survival is 80% at 8 years and 91% at 5 years. Need for additional treatment, 70% don't need, but 20% may need second ablation and 6.5% may need radical treatment. This is important when we counsel the patient. When you talk about focal and hemiablation, there is no difference in recurrence rates. When you talk about learning curve, retreatment rates are reducing over a period of time with proper patient selection, improved imaging, and operator experience. Exception to the usual rule is sometimes we treat non-visible 3+4 with hemiablation if it's a young patient keen to complete family and concerned about his erections and ejection, but not ready to accept radical treatment, and occasionally treat PSMA positive, MRI negative tumors. When we look at trials comparing radical with focal therapy, we look at a propensity matched trial, and we saw that the 3-year failure survival rate, 5 and 8 year are almost the same. This is important because because the patients are under the impression that if they undergo radical prostatectomy, they are cured, which is not. And this is an important slide, which would be a take-home message that can be used to counsel the patient. In summary, with focal hemiablation, less than 1% pad use for incontinence, that's from the HEAT registry. 1 in 3 need tablets for erections, 2 in 3 natural erections, reduction in semen volume in more than 50%, and 1 in 5 need second HIFU by 5 years, and 1 in 15 may need radical treatment in 5 years. Again, focal therapy depends on tumor characteristics, as I said, tumor visibility, location, and next would be what energy you're going to use, whether it is posterior, anterior, whether it is heat for HIFU, whether it is cold for cryo, or electricity for nano. And the treatment plan is accordingly decided whether you want to treat hemiablation or only focused treatment. So to sum it up in my penultimate slide, it is more preference sensitive discussion. We tell them the advantages, we tell them the disadvantages, but at the same time, all options are offered to the patient, including radical, and if they are eligible, then active surveillance as well. So in summary, prostate cancer is a spectrum of disease. Men at low risk won't benefit from treatment. Radical treatment can significantly function impact, but at the time of counseling, all 3 options are offered. Focal therapy offers personalized treatment, 1 to 2% low urine leak rates, preservation of function, excellent cancer control, less than 5% radical treatment at 5 years, and 20% redo focal treatments. Thank you. This is a team of people who I work with, and it's an absolute pleasure. We have Mr. Emberton, who probably would be visiting in mid-August to India, and it's a pleasure to work with all these things. Thanks, Ashwin. I'm happy to answer questions.
Thank you. Thank you, Dr. Santosh. Excellent talk as always. Didn't expect any less than that. So, yeah, we are looking forward to Professor Emberton's arrival. I know he's coming soon. So we're all looking forward to that. Probably I might make a trip to Mumbai. Okay, so Santosh, I have a couple of questions for you.
Yes, go ahead.
So you have now done the whole spectrum of prostate cancer treatment. So you started as a urologist, and then you became a uro-oncologist. Went on to do excellent, good quality robotic radical prostatectomies, and were doing very well. And now you have been doing high volume focal therapy as well for prostate cancer. So for an ideal case of HIFU, uh, which you think you can manage with focal therapy versus radical prostatectomy with good continence in your hands, probably within a month or two, patient is pad free. So what is your preference now, since you have seen both sides of the table?
Yeah, so I mean, that's a good question. It's at the same time there is a little bit of trickiness in it, but I would attempt to answer that, Ashwin. So this is a common scenario we face in the clinic. The patient comes to us after talking to the surgeons, or they go from us after talking about focal therapy. Now, if I am in the seat and if I'm doing both and often, so I'll be, as I said, the discussion involves both, right? We talk about prostatectomy, we talk about focal therapy as well. And to be honest, to be very, very honest, and it's not because I'm doing focal and I'm not doing any disservice to the radical prostatectomies, but we see patients asking to get converted into focal because, as I said, they are very keen on maintaining their ejection, the erectile functions and urinary continence. And I think the awareness has gone up quite a bit. I think it all depends on the cohort. So it depends on where you are counseling the patient, to be honest, Ashwin. But if I'm talking to a patient from India, it would be a different logistics, to be honest. And that's where patient awareness comes into picture. If the patient is really, they are not happy following up with biopsies or maybe PSAs and repeated MRIs, then prostatectomy would be the go for. Again, the explanation would involve what risk they are taking. But if the patient is well informed, which they would be in coming times, they would opt for focal therapy, and we are happy to give them. But again, I would like to mention here that there are cohort of patients who will not be suitable for focal therapy. Like if it is very close to the sphincter, if it's very close to the bladder neck, we cannot offer focal therapy, right? We can't do cryo if it is close to the bladder neck. We can't do nanoknife if it is close to the sphincter. We can't do focal therapy if you have clinically significant disease on both sides. So all these factors do come. So counseling is a very, very big part in focal therapy.
Excellent. So one point that struck me, and I think now as uro-oncologists, all of us are following this, is that a good quality MRI is a must before we do a biopsy. So I think, as Dr. Santosh has rightly put, so MR visible disease, even if it is 3+3, has is more aggressive than those that aren't MR visible. So MR visibility is a key point, and now we have all moved on to either MR cognitive fusion biopsies or software platform fusion biopsies. So I think all the clinicians here should take home that point that before we are doing a biopsy, an MR is very important. And what about post-focal therapy recurrences? And how are you dealing with them? Is it a refocal therapy discussion, or do they opt for radical prostatectomy in your practice in London there?
Right. Right. So I'll give you a quick example, right? So if you divide the prostate into left and right, okay, you treat the left side of the prostate with focal therapy. So the risk of having a recurrence and going for a second focal therapy is 1 in 5 years. The risk of recurrence and not being eligible for focal therapy, but going to radical options is 1 in 15 patients in 5 years. Right? Now, again, now that's the first point. Second point is where the recurrence has occurred. If the recurrence has occurred on the right side, when I've treated the left side, we see what type of recurrence it is. It is called out of field recurrence. Okay. If that is high grade and not amenable to focal therapy, then we ask them to go for radical options. But if it is amenable to focal therapy, we can do a focal therapy. That's called a second focal therapy. A redo focal therapy is done on the same side where he has received focal therapy earlier. All right. Now, if the recurrence in the same side, Ashwin, if it's less closer to the sphincter, we will not offer focal therapy. It's better for him to undergo radical options. So these are called in-field recurrences. So these are things which we take. That's why MRI reading, again, not only before taking up the patient, but after treating also, MRI reading is extremely important.
So excellent answer. I think mental note here for me to involve the radiologists in our next webinar.
Absolutely.
I think just like pathologists, they are sacrosanct to our practice. Thank you, Santosh. It would be great if you could hang around and probably
I
enjoy
will.
Saturday in beautiful London today. And we will be having some panel discussion. So if you can just chip in, we'd be happy to have.
Absolutely.
Thank
Sure.
you. Thank
Thanks,
you so
Ashwin.
much.